All right, today we're going to jump right in and break down how you need to think for the NCLEX, especially when it comes to one of the most high-stakes topics out there, cardiovascular diagnostics. Let's get into it.
Let's just get this out of the way. Cardiac questions on the NCLEX, they're not just some academic game. We're talking life and death. And, as you are about to see, timing is, well, it's everything.
And the stakes? They are ridiculously high. Think about it. If you misinterpret a cardiac marker, that's not just one wrong answer on a test. In the real world, that's a misdiagnosis. That's a critical mistake you absolutely cannot afford to make.
And that right there, that's the secret sauce. The NCLEX isn't trying to see if you can just, read a number from a lab report. No way. It's testing if you truly understand the story that number is telling you. What does it mean for your patient?
So what we're going to do right now is give you a sneak peek into the exam coach's system. This is all about training you to get past just reading the numbers and to start really interpreting cardiovascular data just like the board expects you to.
Okay, let's be real for a second. This is where so many students get tripped up, right? It just feels like this never-ending list of lab values to memorize. You're trying to keep all the different tests straight. You're stressing about what to do before and after a procedure. ECGs look like spaghetti. And, oh yeah, how do all those electrolytes connect back to the heart? It's just a lot. But here's the big mindset shift. The key is not just trying to cram everything into your brain through brute force memorization. It's all about developing pattern recognition and killer prioritization skills. And that's the exact framework we're going to start digging into right now.
All right, first things first. We're going to start with the first piece of the puzzle, decoding the lab data. This is where that whole clinical picture really starts to come together.
So picture this. Classic NCLEX style question, right? A client comes in with chest pain that started 2 hours ago. You get the labs back, and the initial troponin I is just a little bit elevated. So what does that timing, that 2 hours, really tell you about what's going on with that heart muscle?
Okay, so check out how this timeline lays it all out. At the 2-hour mark, you see myoglobin rising. But remember, that's not specific to the heart. Troponin I, which is our go-to cardiac marker, is really just starting to climb around the 3-hour mark. So that initial, slightly elevated number, it's just the first hint. The real story, the trend, is what unfolds over the next few hours.
All right, let's try another one. You're looking at your patient's chart, and this lab value pops up for someone on Warfarin. INR is 4.5. Your brain should immediately go into safety mode. What is the absolute #1 first thing you have to do?
And this is exactly the kind of framework that helps you keep these high-alert meds straight. And you know the NCLEX loves to test this stuff. For heparin, you're watching the aPTT, and the antidote is protamine sulfate. For warfarin, you're looking at the PT/INR, and the antidote is vitamin K. Getting this down cold is step 1 to knowing what to do with that scary high INR.
Okay, now let's connect the dots between a lab value and an ECG strip. You see these peaked T waves, a widened QRS. You glance at the labs, potassium is 6.2. Whoa. All of a sudden, this isn't about numbers anymore, is it? This is a full-blown emergency. What is the single most immediate threat to this person's life?
See, this is so crucial. Electrolytes have a direct and totally predictable impact on the heart's electrical system. High potassium, you get those classic peaked T waves. Low magnesium, you could see a deadly rhythm like torsades de pointes. The ECG is literally a window into the electrolyte imbalance. Recognizing that pattern is the first step to saving your patient.
Okay, let's keep building on this. We're going to move to the next part of the framework. Now we're not just looking at labs, we're decoding the signals from some key diagnostic tests. Take a look at this ECG strip. Right away, you can see it's irregular. And where are the P waves? You can't really find them. This is a classic look for atrial fibrillation. But the NCLEX isn't just going to ask you to name the rhythm. The real question is, what deadly complication do you need to be anticipating because of this rhythm? All right, let's talk about BNP, or B-type natriuretic peptide. This isn't just some other lab to memorize. It answers a very specific question. When the heart muscle gets stretched, like it does in heart failure, it pumps out BNP. So if you see a level over 100, it's a huge clue that your patient's shortness of breath is probably coming from fluid overload due to a failing heart.
Okay, let's switch gears to a procedure. Your patient is on a treadmill for a stress test. They're doing okay, and then bam, halfway through, they grab their chest. They're having pain. What is your single most important immediate priority? What do you do right now?
Remember, the whole point of a stress test is to see if we can trigger ischemia, to see if that physical stress causes a lack of blood flow to the heart. Well, if they're having chest pain, guess what? You've found it. You don't need to push them any further. The immediate action, the only right first answer, is to stop the test. Safety first, always.
Okay, here's a post-procedure curveball you have to be ready for. Your patient is 4 hours out from a cardiac cath. They suddenly call you and complain of a sharp pain in their back, and when you check their vitals, you see their blood pressure is starting to drop. What critical complication needs to be flashing in your mind right now?
This is where having a system is everything. Of course, you're going to assess the insertion site for bleeding. You're going to check the pulses in their leg. You're monitoring the vitals. But that last step, assessing for back and flank pain, that is so important. That could be a retroperitoneal bleed, a hidden hemorrhage that's a massive emergency. Spotting that connection is exactly what the NCLEX tests.
So we've looked at all these individual pieces, right? Labs, ECGs, different procedures. Now let's pull the camera back and see how the exam coach's system puts it all together into one complete clinical picture.
This is really the core logic of it all. See how every test has a specific job. Cardiac markers, they're looking for damage. Coagulation studies, all about preventing bleeding. Electrolytes, they can trigger rhythm changes. BNP signals heart failure. ECGs show you the electrical side of things. Imaging reveals the structure, and the Cath is all about restoring flow. It's not random, it all fits together. And this is what it looks like when it's all laid out. It stops being a random pile of facts you have to memorize. Instead, it becomes this organized, logical framework that helps you turn a whole mountain of complex data into clear, confident clinical judgment. This is how you stop just memorizing and you actually start understanding. So I'll just leave you with this question to think about. As you're studying for your boards, are you just memorizing disconnected facts? Or are you learning how to think like the NCLEX? Are you learning to see the patterns, to prioritize the next action? Because that's the difference a real system can make.